Okay, let's start with lupus. So this is a autoimmune disorder. There are two types. There's a serious one, which is the systemic type, SLE, systemic lupus erythematosus. The minor type, which is also rare, is the discoid lupus. Discoid lupus only affects the skin, doesn't have any systemic symptoms. So this is the more serious and more common type. It's an autoimmune disorder, so we have no idea what causes it. The exact cause is unknown. We have theories, but that's all they are, theories. All right, let's get to the manifestations. It's systemic. So this affects every body system that has a connective tissue. So name one body system that doesn't have a connective tissue. Is there one? Connective tissue is referring to skin, hair, blood vessels, blood.
connected.
Those
All
are
of the connective tissue,
okay.
Professor.
All blood, all body organs, all internal organs have connective tissues. So otherwise we will fall apart without connective tissue. So joints, muscles have fascia. So those are the connective tissues. Okay, the joints, the tendons, skin, the fascia of the muscle, the pleura of the lungs, the pericardium of the heart, the peritoneum of the abdominal cavity, the scrotum of the testicles. These are all connective tissues. So you can just imagine what the patient's manifestations will be. So if all or most of these connective tissues are inflamed, because this is inflammatory, these are the patient symptoms. So we have a long list. This is not even complete. There are other problems besides what's shown in this figure. So we start with the skin. There's that butterfly rash. Looks like a butterfly, runs across the cheeks, across the bridge of the nose. You lose hair. Bone marrow is also connective tissue, so that's affected as well. Patient has pancytopenia, low blood count, low platelets, low white blood cells. And as I mentioned, the connective tissues earlier around the lung, around the heart, around the peritoneum, these are all inflamed as well. So patient will have pleuritis, pneumonitis, pericarditis, peritonitis. The most commonly attacked organ or affected organ here are the kidneys. So you may have known popular celebrities, let's say Selena Gomez, right? She had lupus and she lost her kidneys. Luckily, she got a transplant. Okay, so these are the meaning you don't die from lupus. You die from the complications that result from this disorder. Feel free to interrupt to ask questions, okay? So pain will be common in these patients as they have, because it's a chronic condition, there are flare-ups, meaning we can put them in remission using just like any other autoimmune disorder. So what do we treat these kinds of patients with? Any autoimmune disorder?
Steroid.
Okay, so steroids and then also immunomodulators, right? Since these patients are taking those medications, can they have complications related to immunosuppression? What's the most common? No, just like the Cushing's patient. The Cushing's patient has really high stress hormones, right?
Sugar and blood sugar.
So, yeah, so what happens to their immunity?
Lowered.
Low
They
immunity.
are,
Low immunity.
right, so they will be prone to infections. The most common cause of a flare-up or an exacerbation is stress. Now, stress can come in any forms. It's highly specific to the patient, very unique, but illness is a stressor, correct? So when these patients get an infection because of the treatment for the condition, then that will trigger a flare-up. Okay, So 85% of the cases are the systemic type. Only very few have the discoid, which is minor. Now, the population affected with lupus are actually young, more females than men. Let's look at the incidence right here. So we've got more women, and the age group affected here are between 20 and 40. So these are childbearing age patients. They carried on, of course, to adulthood into older adult. So there's no cure for lupus, so they carry it forever. Although these patients live longer now with advanced treatments, but because again of the nature of the treatment wherein we give them immunosuppressants, so therefore, what do you think is the most common cause of death here?
Infection.
Okay, these patients will eventually get septic and then go into shock, die. Let's look at so I already explained the manifestations. So it's a long list, asystemic. It's not easy living with lupus. And let me go back to the childbearing age. So there's no evidence that they should not get pregnant. In fact, I know a few people with lupus who have children, so they can get pregnant and give birth normally. However, is labor and delivery stressful?
Yeah.
Yes.
Can it
Yes.
trigger an exacerbation, a flare-up?
Yes.
Yes.
So the pregnancy itself also may trigger flare-ups. However, again, we all base it on evidence. There's no evidence showing that the patient will have a better outcome if they terminate the pregnancy versus if they carry the baby to full term. Meaning once the patient gets pregnant, whether they terminate the pregnancy or carry it to full term, they will have a flare-up. So it's the patient's decision now. Let's say this is an issue for, let's say they did not plan the pregnancy and they may be tempted to, because of the flare-up, they'll be speaking with the physician. What should I do? Should I continue the pregnancy? Should I terminate it? The physician's answer would be what I just said. There's really no difference. Makes no difference whether they get an abortion. There's no guarantee that they won't get a flare-up. Okay, they will have a flare-up regardless because it is a stressful event. Another common cause of a flare-up is any skin stressor. Most common stressor is the temperature. So if a patient is exposed to either sunlight or extreme hot temperatures, like summer season, for instance, or direct sunlight, since what's the largest organ of the body?
Skin.
The skin. So once there is skin exposure, ultraviolet rays exposure can cause an exacerbation. Patient will have a flare-up, they'll be miserable. So here, so the flare, especially the skin lesions, are usually caused by sun exposure. So what's the very common teaching we provide these patients? What should we advise them to do?
Sunscreen.
What was that, Mark?
Can you tell them to apply sunscreen?
Okay,
Yeah,
sunscreen, right? So if is sunscreen enough though? Should they
No, stay out of the sun.
All right, so sunbathing.
Avoid sunlight.
Yes, sunbathing wouldn't be a good idea for these patients, so they have to cover up. They can still go out, but stay out of the direct sunlight. They maybe wear large hats or just long sleeves clothing. That way they minimize direct UV light exposure. And here are other problems. You may remember this from rheumatoid arthritis as well. Okay, so rheumatoid arthritis was also a autoimmune disorder. So same, they're at risk for Raynaud's phenomenon as well, just like rheumatoid arthritis patients. Just like rheumatoid arthritis patients, because this is a connective tissue, a systemic connective tissue disorder, there's also joint pain and swelling. In fact, because it's not easy to diagnose lupus, most of these patients, majority, are diagnosed initially with rheumatoid arthritis at first. And later, once they have the kidney damage already, the other body systems, let's say they're now developing pericarditis or pneumonitis, for instance, then the doctor will change the diagnosis. No, they'll tell the patient, "Oh, we made a mistake. This is not arthritis. It's not rheumatoid arthritis. You have lupus," right? But the treatment is similar anyway. These patients are also on methotrexate and other immunomodulators as well. So here are the other serious complications of the condition. Again, pericarditis, myocarditis. So, and the kidneys, as mentioned earlier, patients are monitored. Their kidney function is monitored regularly to see if there's already signs of kidney damage. So patients will usually go into chronic kidney disease and then end up on dialysis, unless they get transplant. As already mentioned, there is no one test to diagnose lupus. So stated here is based on a complete history, a physical exam based on clinical symptoms. The testings mentioned here, testing, let's say, ANA antibody, the rheumatoid factor. So similar tests done for rheumatoid arthritis. Now, the purpose of these tests is only to eliminate other potential diagnoses, so that if we eliminate that it's not rheumatoid arthritis, it's not systemic sclerosis, it's not multiple sclerosis, so they end up with a diagnosis of lupus. All right, any questions so far? All right, let's go to treatment now. There's no cure. We base the treatment on the nature of the disorder, which is again autoimmune. So these patients will be taking several immunomodulators with exacerbations when they have flare-ups. Just like rheumatoid arthritis, they'll be placed on steroids, high-dose steroids, in order to shorten the period of the flare-up so that they can go home and back to their own lives as soon as possible. As already mentioned, the life-threatening part of lupus is the exacerbation. It's the complications that result from this disorder. Most of them are related to treatment as well. So the infection is because of the drug therapy we use. And then is pericarditis life-threatening? You remember pericarditis from last semester?
Yes.
Was it pericarditis that was life-threatening, or the complication of pericarditis?
The complication.
What do you call that complication again? The life-threatening complication from pericarditis? And there were 3 signs. There was the Beck triad, which were muffled heart sounds, hypotension, jugular vein distension.
Yeah, JVD, yeah. JVD.
What do you call that condition, which is life-threatening, resulting from pericarditis?
Cardiac arrest.
Close. Cardiac what?
Cardiac
Go ahead. It's at the tip of your tongue. I can see it. Was cardiac tamponade, correct?
Yes, cardiac tamponade, yes.
Cardiac tamponade. So lots of potential for this patient to die. Okay, again, not directly from lupus, but the complications that result from the disorder. Here's the treatment. Because the patient has pain, and this will be the patient's priority, they're in pain, they have joint pain, they have bone and muscle pain, they have fatigue. So they'll be given NSAIDs. And because these are long-term NSAIDs, long-term use of NSAIDs, what will be added to the therapy? Knowing the patient will develop potentially peptic ulcers,
PPIs.
or
H2 blocker.
one more.
The Pepto-Bismol.
No, that was to coat the ulcer. How do we prevent the ulcer in the first place?
Antacids.
Not really.
Sucralfate.
We have PPI or H2 receptor blockers, and one more, which is it's a prostaglandin analog, because NSAIDs inhibit prostaglandin, so we give them a prostaglandin analog to replace prostaglandin.
The calcium.
It was misoprostol, remember?
I see.
The drug used for abortion?
Yes.
Yeah, okay. So of course, before we start that drug, make sure the patient is on birth control, okay? At least 2 methods of birth control, knowing that the drug can cause abortion, okay? So they must not be planning pregnancy when we use that drug. All right. So these are the groups. So we'll put the patient on. These are expensive. Monoclonal antibodies are expensive. Steroids you know about from Cushing's and Addison's. We have anti-malarial agent, which is hydroxychloroquine. NSAIDs, that's Aleve, ibuprofen, and immunosuppressive agents. So we have a list here in the next succeeding paragraphs. So this is the expensive monoclonal used to treat lupus. Then we have the steroids. Again, when do we use steroids again? During
Flare up.
Okay, during flare-ups, during exacerbations. We typically don't put them on, because what will happen if we put them on it indefinitely?
Immunocompromised.
And what will
resistance.
they will develop? Cushing's.
Oh, Cushing syndrome.
Right, okay. So we only use it minimum necessary, especially for flare-ups only. However, we can use steroids every day, only topical. This is for the rash on the skin, okay, to minimize the butterfly rash. Remember, these are 20 to 40 years of age. These are young women, and it's not good having the rash on your face, right? Especially if you're still single. The anti-malarial medication, hydroxychloroquine. The danger here is this can cause cardiac dysrhythmias, among other side effects. There'll be a list later in the chapter. And the immunosuppressive agents are the following. So a patient will be placed on any of these. I mentioned methotrexate earlier, the one used in rheumatoid arthritis. Azathioprine is also common and then not very expensive. Cyclophosphamide and mycophenolate or mycophenolic acid. Mycophenolic acid is also quite cheap. Okay, I've seen many patients on it. It's approved by most insurance. So nursing care is based on the symptoms. So we support the patient Again, think of a 20 to 40-year-old patient with these manifestations who have pain, fatigue. What are you doing? You guys are between 20 and 40. So what is a typical woman at that age doing?
Having kids.
Right? So you're
Okay.
either school, yeah, you're working, you have your career, your RNs, right? You have your families, or you're starting a family, for instance. So it's not easy. And you have this disorder to deal with, so it's debilitating, especially when you have flare-ups. It can disable you, not to mention if you have kidney involvement, then that's another thing you have to deal with, the loss of your kidney, and then you'll end up on dialysis while waiting on a transplant, right? So it's not easy. Teachings will be to minimize the risk. The skin, remember the skin care, so avoid extremes of temperatures, avoid direct sun exposure, use sunscreen all the time. What would be the best SPF number for sunscreen for these patients?
1,000.
That's a little too much. So what's the minimum? 30, right? 30
30.
SPF 30 or better. So the higher the SPF, then the better protection. Avoid stress, which is not very easy, especially you guys, you become nurses. It's a stressful profession, but don't add any more. Let's say smoking, so avoid smoking or any, first-hand or second-hand or third-hand smoking. No, stay as healthy as possible. Develop good healthy habits, right? And very important is teaching to avoid situations that place them on at risk for infection. Let's say going out to nightclubs, for instance, places with very crowded, where you're likely to get something like the flu or COVID maybe, right? Again, not easy. These are young women, 20 to 40. This is what you normally do. And if you isolate, you don't go with your friends to clubs, then what happens to the patient psychologically or emotionally or so?
Depression.
All right, so that's another thing they have to develop. Patients get depressed, and then who knows what else. The therapy, again, besides the immunosuppressants, remember this, they can still potentially develop Cushing's. So that's another thing on top of lupus they have to deal with. Remember this? This was also mentioned in rheumatoid arthritis. So this can also develop. So this syndrome causes dryness of the mucous membranes. So this can result in dry mouth, dry rectum, dry vagina, dry everything. So that can lead to painful intercourse, painful defecation, right? So that's one more thing they have added. That's about it for lupus. Any questions? For drug questions, now the never mind, because the medications here are repeated when we get to multiple sclerosis. So that's under the neuro chapter. But these patients taking some of these immunomodulators, belimumab definitely is IV, but some of the immunomodulators used here are subcutaneous injections. So these patients will have to self-administer the medications. So that's one more teaching you have to do, a self-administration of the subcutaneous injections. Any questions on lupus?